I'm Adair Call and we'll be performing a live ultrasound evaluation of the shoulder. This video is not meant to be a comprehensive review of this topic. Rather, our objective is to cover the core competencies as outlined in the AMSSM Recommended Sports Ultrasound Curriculum for Sports Medicine Fellowships. We'll begin our shoulder evaluation with the biceps tendon. And for this, we'll have the patient in a supine position with the forearm supinated so that we have a nice view of the bicipital groove. We'll use that as our bony acoustic landmark to identify the long head of the biceps tendon, which is represented by this echogenic structure we're outlining here on the screen. We'll want to evaluate the full caudal and cephaloid margins of the biceps tendon. So once we identify it in the groove, we'll move distally down until we see the pectoralis major tendon coming across, which is represented right here. And this will occur right at the musculotendinous junction of the long head of the biceps. So we see right here the beginning muscle fibers of the long head of the biceps with the short head of the biceps muscle lying adjacent. So the pectoralis major tendon is a rather broad tendon. We're continuing to see that in its long axis as we come down as the long head of the biceps muscle continues to enlarge. We'll then move back up superiorly and then pick back up on the tendon. This tendon is going to curve as it comes up, so we'll have to constantly angle our transducer to correct for any anisotropy, so we keep the tendon nice and echogenic as we come up into the groove. We see there we get a little anisotropy, so we'll just readjust our transducer wag and we'll continue to follow it up. As we get up higher, it's going to start to turn, once it gets into the interarticular portion, it's going to turn in to go on to its insertion in the labrum. So we'll have to rotate our transducer slightly, as you can see here, to keep the short axis view of the biceps tendon. And at this level, we're starting to move towards the intraarticular portion. And so we know we're intraarticular because we're beginning to see articular cartilage forming here in the lateral and medial aspects. And we can also see the tendon will get a little bit more oblong in shape, and that's as we continue to follow it up. Now at this level here, we can see nice articular cartilage. So we see this cartilage interface sign as we're in the rotator interval at this point. Here's our anterior margin of our supraspinatus, and our subscapularis tendon sits over here. So this would be the rotator interval with the long head of the biceps in its intraarticular portion. Also within the rotator interval will be our coracohumeral ligament and our superior glenohumeral ligament, which we can see forming the pulley around the biceps tendon at this location. So you can continue to follow this up a bit, but at some point we will lose the tendon and we're not able to follow it all the way to its insertion under the labrum. So this is an adequate portion to follow it up to. We'll then come back a bit into the groove again, reorient there. It's helpful to look for the neurovascular structures, particularly if you're going to perform any intervention. This most typically will sit in the lateral aspect of the groove, and we can sort of see some beating of that ascending branch of the anterior humeral circumflex artery right around here. We can also put the Doppler on and identify that as well, so we can see it beating nicely right there. There is some variability, so it's often helpful to put the Doppler on when identifying the vasculature here. So next we'll turn into a long axis view of the tendon. So we'll rotate right on it there in the groove, and now we can see the nice fibrillar echo texture of the biceps tendon as it comes down. And we can follow this all the way down to the muscle tendon junction, which we see forming here. Over top is going to be a short axis view of that pectoralis major tendon. We can see, again, it's a broad, flat tendon inserting over top of the biceps here. So we can follow this all the way back up in the long axis, all the way to its intraarticular portion. And again, we'll have to rotate our transducer slightly so that we can stay over the long axis of the biceps tendon. At this portion, we're getting up again into the rotator interval and then up into the intraarticular portion, which we can see here. So last, for any biceps instability, so particularly if patients have a complaint of popping or snapping about the shoulder. And so for this, you can often ask the patient to reproduce their snapping complaints. If they're unable to do that, then we can have the patient come up into some flexion at the elbow, and we'll bring them into internal and external rotation while visualizing the tendon. And so we'll bring them back and forth through here, and just to look for any subtle instability or movement of that tendon coming over or into the subscapularis. So we can see here we don't really see any motion. This looks nice and stable. So we'll then, in this position, continue to externally rotate the shoulder, and then I'll often have the patient rest their arm either on my leg or on the ultrasound cart if need be, just to provide them some support, because this can be uncomfortable if they have shoulder pain. From here we'll continue to move medial until we are able to visualize the coracoid. So we have our nice hyperechoic linear echo here of the coracoid. And then from there, we'll come out lateral and visualize the subscapularis tendon. So this is a good bony landmark to use. And this is also the area where you may see any subcoracoid bursitis in this plane. So we can, again, evaluate that dynamically with internal and external rotation, looking for any impingement or bursal fluid at that interface. We'll then come out. Here we're seeing a bit of the muscular tendinous junction of the subscapularis. Here we see articular cartilage along the humerus, and we'll come out towards the lesser tuberosity, and here's the footprint insertion of the subscapularis in this long axis. And we'll want to evaluate that through its full caudal and cephalad margins, and then we can rotate in short axis over the tendon as well. In short axis, this tendon often will have multiple tendon slips that can be visualized. You'll see these hypo or anechoic linear fissures coming down through the tendon, and that's all normal. So don't overcall that as small little full thickness tears within the area. So again, you can scan to the coracoid, which we see here, and then we can follow that back out and then follow the tendon all the way down to its insertion on the lesser tuberosity. So that completes our subscapularis evaluation. Next, I'll have the patient just go back into a comfortable position with the shoulders. They don't really need to be in any degree of internal external rotation, and we'll move up to evaluate the AC joint. So for this, we'll decrease our depth and bring our focal zone up. And we will see the clavicle here on the right side of the screen and the acromion on the left side of the screen. So here we want to look for any effusion within the AC joint. We want to look for any cortical irregularities, in younger patients, particularly along the clavicular side, which may represent distal clavicular osteolysis, or more generally, which may represent simply degenerative arthritis. So you can see ganglion cyst here. You can see effusions. In the case of a massive rotator cuff tear with associated arthritis, you may actually see a geyser sign where fluid from the glenohumeral joint may come up through an incompetent inferior capsule and then form superficially over the joint. So all things that you can appreciate. In the setting of acute trauma, you can also do dynamic scans here to look for any instability of the joint, often bringing the patient over into some cross-body adduction or performing different provocative maneuvers for that. For our infraspinatus evaluation, we have the patient lying in a side-lying position with their arm just relaxed by their side to start. Here we can simply put the transducer down over this location and identify the central tendon of the infraspinatus. Alternatively, you can come up to the spine of the scapula and put the transducer over that area, and here we see this posterior acoustic shadowing from the spine. Slide just inferior to that, and then you'll start to see the infraspinatus here, and then you can orient your transducer to become in long axis with that central tendon, and then we can follow that out laterally all the way around towards its insertion site. And so this is the tendon of the infraspinatus here. This is muscle of infraspinatus here. So as we come around, oftentimes we may see a little bit of cortical irregularity in this area. And so this is nothing to be considered abnormal, at least at this degree. So a small amount of irregularity here can be normally seen, and it doesn't have the same significance as it may along the supraspinatus and the greater tuberosity. So just to keep that in mind. So as we continue to move back medially here and the long axis of the infraspinatus, we'll begin to see the posterior aspect of the glenohumeral joint. So here's the humeral head. We have articular cartilage here. This is the glenoid. And this hyperechoic structure here represents the glenoid labrum. If we continue to move further back medially, we'll begin to see the spinoglenoid notch. And to get this into better visualization, we'll take the medial aspect of the transducer and rotate it slightly superior, and now we have a nice view of that notch. Here we want to assess for any cystic structures, most commonly seen associated with labral tears, that may cause some compression of the suprascapular nerve. It may lead to some external rotation, weakness, as well as pain. We can see a pulsatile nature of the artery back here. You can occasionally pick this up on the Doppler scan, although at this depth sometimes it's a little bit difficult, but we do see that artery there. It's a little bit, you have to overgain just a little bit to get it to come up well. Now, a pitfall of imaging here is if the patient comes into external rotation, you can see venous engorgement of that area. And so we'll bring the patient back into internal rotation, we see that go away, come into external rotation, and we can see that venous engorgement again. So this should not be confused with a cyst within the spinal glenoid notch. Always make sure you have an idea where the patient's arm position is, and don't overcall normal venous engorgement for a cyst. So now we'll turn our attention back to the infraspinatus itself, and we'll go into a short axis view to evaluate the muscle echo texture. And so here we have superior on the left side of the screen, inferior on the right, and we can see the short axis view of the muscle spinatus, and here's that central tendon forming here. So if we continue to come inferior, we'll see the teres minor sitting more inferior in this aspect here. The teres minor often functions as a good control muscle because it's rarely involved in traumatic tears or degenerative tears of the rotator cuff. And so we can look at relative echogenicity of both of those muscles to see if there's any fatty infiltrate of the infraspinatus. We can also just evaluate the muscle echo texture to ensure that we can see the pinnate structure of the muscle as well as the clearly delineate the tendon within there. If you're having difficulty seeing that, then it's often because of fatty infiltration, and this whole area will become more hyperechoic, similar to the tendon. So if you're not able to identify that central tendon, then that would be considered a high-grade fatty infiltration. So we can follow that tendon to the short axis just like we did in the long axis all the way out to its insertion site here. We'll see an artifact coming from this muscular septum within the deltoid above that's casting some shadow along the tendon, so don't confuse that with focal anechogenicity or hypoechogenicity of the tendon. We'll then move inferior, and we'll see in short axis the teres minor tendon down here along the inferior facet. We can then follow that back medially, and we'll see the muscle belly of the teres minor. So if we follow that back out to its insertion in the short axis, we can then rotate on that and get a long axis view of the teres minor. Trying to get on here. And this is a small tendon. It's often a little bit challenging to get directly over and in line. And so here is that insertion site of the teres minor tendon coming back towards the muscle tendon junction. So it's a much smaller tendon, and so I recommend trying to evaluate it in the long axis only by turning on it from the short axis evaluation. It's quite difficult to get over if we try to just find it in the long axis. So there's the teres minor. So after evaluating the infraspinatus and teres minor, we will then move up to the suprascapular notch. So we'll again place our transducer on the spine of the scapula and bring it just over and shooting deep, and then we'll increase our depth, and then we clean up our margins to visualize that suprascapular notch, which we can see here. And this is another area where we'll assess for any cystic structure sitting within the notch that may be causing compression of the nerve. We can again visualize some pulsatility of the artery in this area. And we can try to look with Doppler again. At this depth, often it can be a little bit challenging to pick up, but we do see if we overgain it a bit, we can appreciate the artery there. Now, on this level of the suprascapular notch, we're visualizing the long axis of the supraspinatus muscle over top, and so that's what this represents here. So we can follow that muscle out laterally, and we'll come to a point where it begins to move under the acromion, so we will lose our image there due to the posterior acoustic shadowing of the bone. And as we continue to move lateral, then we'll pick up the tendinous portion of the supraspinatus in the long axis as it comes out to its insertion site. So at this point, we'll readjust our depth. We'll bring our focal zone up. And then we can ask our patient to come back into a modified CRAS position. So I simply ask them to bring their elbow straight back towards me. The advantage of doing this scan with the patient in the sideline position is now gravity is going to help us here by bringing their elbow and keeping their elbow back, as opposed to in the seated position where they can often let that elbow flare out a bit, which can degrade our image. This is often much more comfortable for patients as well, and I typically don't have to do anything more than just have them come back and allow their hand to rest on their side. You can bring them back even further into extension if need be, but we can see in our model here, we have a nice view of the tendon. So in the long axis, we'll continue to move anteriorly all the way until we identify the long head of the bicep again, which is right here. Now when we know we're in the rotator interval, we know we're beyond the anterior margin of the supraspinatus, so then we'll come just back, and now we've ensured that we've looked at the entire anterior aspect of that tendon. You can see here the tendon looks a bit dark, and this is a normal finding of anisotropy. So for that, we're going to correct by heel toeing our transducer, and now we can see we're able to fill in all that area with nice hyperechoic fibers. So this is another common pitfall in rotator cuff imaging, and you'll almost always see some hypoechogenicity in this region just because those fibers are curving down. So you always have to heel toe your transducer to bring those fibers in. So we'll come back. Again, this is the footprint here. This is the articular cartilage. So this is going to be the articular surface of the supraspinatus. Bursal surface lies up here. The bursa continues beyond the footprint of the supraspinatus, and this can be helpful in trying to identify those two tissue layers. So we can see here this tissue that comes beyond the footprint. As we come back, this is all bursal tissue here, and then this is supraspinatus, and then down to the articular cartilage. So it's important to recognize your layers of tissue here, which can be very helpful, particularly in challenging scans. And so starting at the very top is the skin, which is a hyperechoic structure. Then in our model here, we have a very small layer of subcutaneous tissue represented here. We then get down to the deltoid, which is this darker structure we see here. Then we will have the hyperechoic peribursal tissue. You can often appreciate a small anechoic line within this bursal tissue, which represents the small amount of physiologic fluid within the bursa, which we're not seeing much in our model here today. And then we'll come down to the tendon itself, and then down to the articular cartilage, and down to the bone. We'll want to continue to scan all the way from the anterior aspect all the way posterior so that we are able to identify the entirety of the tendon. As we come back here, we'll start to see that our fibers are no longer looking to be in, and that's because we're back at the overlap or intersection with the infraspinatus tendon at this portion. And I feel that's a little bit better evaluated than the short axis. So we'll turn on a short axis view by rotating our transducer, and the first thing we want to do is identify the long end of the biceps tendon again. So this will be our landmark to ensure that we've looked at the far anterior aspect of the rotator cuff. So here's the biceps tendon, and then we'll begin to move back posteriorly from that, and this is a short axis view of the supraspinatus, and as we continue to move back, we'll begin to see the infraspinatus coming in at this level here. And so now we're in somewhat of a long axis oblique view of the infraspinatus, and as we come back forward, we'll get over the supraspinatus tendon in the short axis view here. So this is how we would make any measurements of tears in the anterior to posterior dimension by using the biceps as our landmark and coming back. If we scan up in the medial direction, we'll again see articular cartilage forming here at this level. And here's our subacromial bursal layer. If we come out distally or laterally, what we'll see are the facets forming, and this can help us identify which tendon is which as well. And so this will be the middle facet. This is where the infraspinatus will insert with some overlap of the supraspinatus, and then the superior facet here is all going to be supraspinatus. And so if we come back up medially or proximally here, we'll again be able to appreciate supraspinatus, and then oftentimes you can just appreciate that junction zone because you'll see the fibers are coming in slightly different from the supraspinatus below to these infraspinatus fibers that are coming in now in this direction here, so we can start to see the overlap zone right here.
So in the short axis view, you can also move all the way back over the muscle belly of the supraspinatus by decreasing our depth or increasing our depth here. We'll see the short axis view of the supraspinatus. And similar to the infraspinatus, you can compare this to the and look to make sure you can identify the tendon and the pinning structure of that when looking for any atrophy or fatty infiltrate. Lastly, we'll want to come back out and again get a long axis view of our tendon. We'll readjust our depth. We want to make sure we have the acromion in view and a nice long axis view of our supraspinatus tendon. From this point, we'll do our dynamic evaluation for impingement. So we'll ask the patient to come up into abduction, and we'll anchor our transducer right there, and then we look to make sure that the supraspinatus clears underneath the acromion. We don't see any bunching of bursal tissue or any pooling of fluid within the bursa, and also that they don't have pain while they're doing this. We want to have the patient do this actively if possible. It won't give us the same information if it's done passively. Excellent. We can see nice normal motion of that supraspinatus tendon, no bunching of tissue, no pooling of fluid, and no pain like this. And that will complete our basic evaluation of the shoulder. Thank you.